Good morning, Pradipta sir. Can you hear me?
Yes, sir, you are audible, sir.
Well, I think she'll be joining in a few minutes. Meanwhile, with a video. Can I do that?
Sir, let us start this particular session. So before you start, I will take 1 minute from you, right?
Okay.
So good morning, everyone. Good morning, good morning, everyone. Warm greeting to one and all. On behalf of Dr. B.C. Roy Engineering College, Academy of Professional Courses, I, Pradip Topal, extend a very sincere and warm welcome to one and all present here. And also, I want to extend a note of thanks to our key speaker, Dr. Surajit Chakraborty and Ms. Ramyani Bhattacharjee from Priyambada, Birla, Aravind Eye Hospital, Kolkata. So it's our privilege to have among us the glaucoma specialist from a renowned eye hospital from Kolkata. So before I start this particular session, I would like to announce one thing, that you will have the opportunity to submit the text questions to your today's presentation by typing your questions into the chat panel. You may send your questions at that time during the presentation. We'll collect these and address them during the question answer session at the end of today's presentation. Now, I'd like to invite our respected principal, Dr. Arunabha Mukherjee, for further proceedings. So, welcome, ma'am, and it's now over to you.
Good morning, everybody. Good morning, all the dignitaries online, and a very warm welcome to Academy of Professional Courses, sir. We have taken this time today on Sunday so that we could actually meet online, irrespective of our, week-long busyness, rather, we say. And it is indeed a proud privilege for us at Academy of Professional Courses, after running for 15 long years, that we have a proud association with Priyamvada Birla. And we have already started off with the optometry division, and Dr. Atanu has been coordinating on our behalf with you all. Currently, we are running 6 courses as such. We have a BBA, BCA, Supply Chain Management, Hospital Management, Optometry course, and the course in Medical Lab Technologies. And to just inform you all, we have successfully placed 15 batches, and we are really proud of our students who have already left a mark in the corporate world. At the onset of this glaucoma week, World Glaucoma Week, we have arranged this seminar because we feel that glaucoma has become one of the most common causes of irreversible blindness of these days. And it's a very, very contemporary topic. And we have with us, we are really honored to have with us Dr. Surajit Chakraborty, who is the Chief Consultant of Glaucoma's unit of the Priyambada Birla Aravind High Hospital, Kolkata. Welcome, sir. Welcome, sir. And I just hand it over to you for the further proceedings. And we look forward to a very, informative, deliberation from you. Thank you very much. Over to you.
Thank you, Dr. Nava. And at the outset, I'd like to tell all of you that more than a talk, we would like more interaction in this session. So please, the moderators and the panelists, please, all of you, send out the questions that you are having from the audience, so that and let us start our session with a small awareness video. It is not a very small video, but it will contain most of the information that you like to know about glaucoma. There is no financial interest. That video is being made by a company, and I think there is a nice compilation of the information that anybody should know. And let me share this. Well, can you see the?
Yes. Yes, sir.
Yes,
it is
sir.
visible.
Okay. Good.
Yes, sir. Yes, sir.
Okay, good. Good. Let me just play it.
Sorry to interrupt you, sir.
Yes.
This video is not having any sounds.
Wait, coming up. Sound is coming.
Video is coming, sir. Sound is not coming,
Okay.
sir. So if
Is there
anything
anybody from the technical team who can help me? Because in the Zoom platform, I used to do this basically, and it comes usually. And is there any separate arrangement or any issue?
nothing, sir. No such
Okay,
separate
most of the,
settings are required, sir.
sorry?
For video presentation for this
Yes.
audio, no such separate settings are required, sir.
Can you help me with what kind of settings? Anyway, let me see if I think it will be a problem. I just stopped the sharing, and let me see if it gets any better.
Sir, one thing you can do, like you can put your microphone in front of your laptop speaker so that the voice is coming in case of any technical glitch, sir, we can hear the sound, sir.
Okay. No, it doesn't help basically. Anyway, I'm trying once more. Just to see. But most of the minutes will be displayed, so you don't miss too much. Is it audible now?
Not audible, sir, but we can go through the messages, sir.
Yeah.
In the early stages, glaucoma are there different types of glaucoma? There are two major types.
Okay, so I hope you, though you could not, but you could see the instructions on display, and that is a nice compilation. And from this presentation, you start thinking about your questions, and we'll come to the main presentation for today. That will be a slightly
Sir, you have muted yourself. Please unmute.
Oh, okay, good. Thank you. Actually, it got muted during the video itself. Anyway, so that was a nice compilation. I think you could see the messages displayed on the video. So you start thinking about the questions you're going to ask, and I really need it to be a interactive seminar. And now we'll go to the next presentation. That will be a little more detailed presentation on glaucoma, starting from the basics once again. And Mrs. Ramyani is also here. Now she has joined. I think she will be chipping in between during the optometrist, the diagnostics parts. And so without delaying much, let me start the main presentation. Visible now?
Yes, sir.
Yes, sir.
Okay, good. So what is glaucoma? Previously, it was thought to be any condition in which the intraocular pressure is higher than normal, with resulting damage to vision. And now the definition has changed. Now the intraocular pressure, higher than normal intraocular pressure, has become secondary. It is observed that many a times with even a normal intraocular pressure, glaucoma occurs. So the current definition is primary angle closure glaucoma is a multifactorial optic neuropathy characterized by acquired loss of retinal ganglion cells and optic nerve atrophy. So it's a multifactorial disease mechanisms, and glaucoma name itself doesn't mean it's one disease. It is a multitude of diseases. Together they are called glaucoma. So next, why is it important to know about glaucoma? Because it's a essentially preventable blindness, and more awareness is required about glaucoma so that it can be prevented. It cannot be cured. That is the main reason we all should know about glaucoma. And if you look at the burden of glaucoma, it is one of the most challenging and most frequent cause of blindness. Then the glaucoma, people have become blind due to cataract, but that is reversible. This is the cause of irreversible blindness. So more than often, without knowing, people can have glaucoma and there will be absolutely no symptoms. This is fondly called as silent thief of vision. So that's important. And as I told, it is the second cause of blindness after cataract, but it's a prime cause of blindness for irreversible blindness. And more than 7.6 million people have become blind, and with 80 million people are affected with glaucoma worldwide. So how does glaucoma damage the optic nerve? You'll be knowing the normal anatomy of eye, that something called aqueous humor is there inside the eye, which is produced at some part, and it is drained through some other part, and that continuous formation and drainage maintains the intraocular pressure. I think if somebody is not muted, please mute your. Some noise is coming. Ramyani, you can mute yourself for the time being. Okay. So this dynamic equilibrium between formation and drainage of aqueous humor maintains the intraocular pressure, which if gets blocked, the passage gets blocked, the intraocular pressure becomes high and there is some damage. So this is the basic mechanism. But please remember, glaucoma is not a simple thing. It is not a unidirectional or unidimensional disease. There are other factors also, for example, ischemia, which causes a damage. So there are mechanical theories, the intraocular pressure related, that is definitely there. But there are other mechanisms also, like vasogenic mechanism. Because vasogenic mechanism is nothing but inadequate supply of oxygen to the vital part of the eye, which causes a damage of that part, the optic nerve nutrition, due to ischemia. Ischemia is nothing but reduced supply of oxygen to that part. And obviously there are genetic issues also. There are many chromosomes identified with different kinds of glaucoma association. And please remember, there lies the importance of a family glaucoma screening. If somebody is having a glaucoma history in the family, the primary screening has to be done for the siblings. That means if somebody is having a glaucoma in the family, his brothers and sisters has to be screened. And next comes the offsprings, and the next generation. They have to be screened for glaucoma. Coming to the types of glaucoma, please remember, glaucoma is not always a disease of the adults. There are the common types like primary open angle glaucoma and primary angle closure glaucoma. But also there is some entity which is called congenital glaucoma that accounts for a very small percentage of patients. But congenital glaucoma means it can be present since birth. There can be some developmental anomaly in the eye. That means during formation, the eye has not been structured properly, and some defects in the outflow passage of the eye, the aqueous can get collected inside the eye, leading to high intraocular pressure, and that can cause glaucoma. That is called a congenital glaucoma. And there are other glaucomas called secondary glaucoma. Secondary glaucoma, not the primary glaucoma. They are secondary to some other disease. Some other problem has occurred. That's why glaucoma has started with high intraocular pressure and all that. So those group of diseases are called secondary glaucoma. A few words about congenital glaucoma. You can, many a times you will see babies with large eye, large blue kind of eye. And people may think, what a nice looking baby, what a nice big eyes. But it may be a symptom of congenital glaucoma. Please be aware and be careful to detect this kind of situations, or else that baby may be his or her life. Because unless you are treated a congenital glaucoma very early as possible, the vision is going to go. The symptoms can be watering, intolerance to light, and defective vision, does not identify mother and bumps into objects. And signs can be enlarged eye, white hazy cornea, or be like this. I hope you can see this picture. Next comes the primary open angle glaucoma. This is the silent killer, the silent thief of vision, because it gives no symptom, and very slowly, very subtly, the vision keeps on going without any symptom. And it is diagnosed on a routine eye examination. Please remember, a routine eye examination extends much beyond the spectacle correction. So there lies the importance for everybody, particularly the optometrists, to know, because you are the first point to which a patient comes. So everybody should know that there is something called glaucoma, and not only you'll get, I mean, in most of the cases you'll not get any symptom in the eye, not also after examining the spectacle power, because everything will be fine till you look into the inside of the eye. You'll not realize, or in some stray cases you might find high intraocular pressure on routine examination. But high intraocular pressure is not always the case, so please be aware that you need to know how to examine the inside of the eye nerve, and please see the optic nerve, please see the appearance of the optic nerve before you leave the patient. And a few words on that will be to see the angle of the anterior chamber is also very important, because angle of the anterior chamber will tell you whether the patient is having a primary angle closure, because angle closure is also very important, because it's sight threatening, though there are symptoms initially and early, but the progress is also very rapid. So these two things, one, looking at the angle, and next looking at the optic nerve, these two things will screen out a lot of glaucoma patients who are going to go blind unless you're detecting it early. Regarding POAG risk factors, practically anybody can have a primary open angle glaucoma, but few salient risk factors are increasing age, more than 40 years of age, family history, just what I said, a positive family history means his brother or sister has to be examined very early, and next comes the next generation, son or daughter, or maybe nephew or niece. And extreme long and short-sighted patients like hypermetropia, that is extremely high plus power or extremely high minus power, high myopics, are also more prone to have glaucoma, and often they are misdiagnosed as glaucoma. Interestingly, diabetes mellitus is also associated with glaucoma, and somebody who is on drugs, steroids in any form, can have glaucoma. What I was going to tell you, interestingly, glaucoma is a disease which are more often underdiagnosed and overtreated. That's a very rare thing. It is often underdiagnosed and overtreated. People who are having glaucoma does not get the treatment, and people who are not having glaucoma get treatment many a times. So you need to be very specific and very careful. Optic nerve damage, it occurs, and that is the hallmark of glaucoma. Coming to the angle closure glaucoma, it occurs in old age, more common in with potentially vision threatening as it progresses very early, present to the doctor early, and with immediate symptoms. There may be high intraocular pressure, redness, and congested eye. Congested means very red. You can see if you see the picture, red eyes with pain, and many a times you will find that the patient has gone to medicine ward for headache, and from there it gets referred back to the ophthalmologist for an eye examination, and you will see that it is not a case of headache or neurological thing. It is just angle closure, acute attack of angle closure glaucoma. And the importance of knowing about angle closure glaucoma is the treatment is very easy if you detect early. Small laser iridotomy often cures the condition. Often it doesn't let the aqueous collection behind the iris, and this acute attack never happens. So knowing about the laser treatment for angle closure glaucoma is very important. And also there are, yes, surgeries also there. And secondary glaucomas, which are not primary, and they follow due to some other problem. This is a long list. I'll just show you the list. You know the name of the entities that can cause glaucoma. Just going through the list, and mention will be there. For example, many patients will ask you what is going to happen if I do not get operated for the cataract. It can cause a long-term effect of the lens with the lens swelling or lens matter leaking out of the lens and cause a lens-related glaucoma, which are very potentially blinding. Neovascular glaucoma, it is often associated with central retinal occlusion, diabetes mellitus, central retinal artery occlusion, long-standing retinal detachment, and other things. Pigmentary glaucoma, these are a few more names of the secondary glaucoma. Obviously, if somebody is using a steroid drop indefinitely, so there is one message from our side to the patients: please do not use any medicine, any eye drop without the advice of your doctor, because we do not know what the exact active ingredient is there. If some steroid is there, it should be used with very caution. Unsupervised use many a times in glaucoma. And malignant glaucoma is a misdirection of aqueous humor which was produced from the side, and if it is misdirected, it can cause glaucoma. And other things like episcleral venous pressure rise due to intraocular hemorrhage, like in a traumatic hyphema, traumatic hemorrhage inside the eye. Before going to the investigations and examination part, let me look at the anatomical considerations. In the investigation, as my following speaker, Ramyani, will tell you, that the field defect in the eye will have some certain patterns. And mostly, if you look at the anatomy of the eye, that means the structure in which the optic nerve is made, or the retinal nerve fiber layers are arranged, you'll find that there are a few bundle of fibers. If this is the optic nerve, and these are the retinal nerve fiber layers, and these are the retinal nerve fibers, there is one bundle called papillomacular bundle, which is going straight to the optic nerve, and the others just curve superiorly, that means upwards and downwards, to reach the optic nerve. So in simple terms, if you think as a structure, you have a building, and in the building you have different electrical wires, and all the electrical wires, they do merge somewhere. Where is that spot? That is at the main switch of the building. So main switch is this one. From here the optic nerve forms, and these are the wirings which converge to the main switch. Okay, so you see the change in the main switch, that is the optic nerve, but there are the small defects which contribute to this change in the optic nerve. Those lie in the retinal nerve fiber layers. So our investigations, our detection of problem lies with the detecting of this retinal nerve fiber layer damages anywhere. That may be a functional test like a visual field test, or a structural test like OCT, or some other like HRT, some tests which quantitatively measures the thickness of the retinal nerve fiber layer. Okay. Basically, the disc cup, what we talk about the optic nerve, there is a cup portion, there is a rim portion. The disc cup is the difference between the number of actions. Actions are the nerve fiber things, and going through, and the available size of the hole. Like if you have a lot of wire passing through a small pipe, you will see that all the wires are very much congested, and there's hardly any gap between these two. So you will think that the cup portion is less. But if the hole of the pipe is smaller, you will realize that the portion is normal. At the same time, Some message from Ashish Saxena is requested to annotate the shared content. I don't know what to do. Is anyway. So where I left, it was if the canal is small, if the pipe is small, the same number of wires going through it may one. While with a larger pipe, the same number of fibers may make you feel that they are spread over a larger area and there is a big central gap and there is some defect. Actually, no. The same number of wires, same number of nerve fibers are spread over a larger area. So there is no decrease in the number of the nerve fibers itself. And both this disc, the small disc with a small cup and the large disc with a large cups, both can be normal. Particularly, this is common with high myopes. In the high myopic patient, when the overall length of the axial length of the eyeball is more, the same number of retinal fibers are spread over a larger area. So one can find the optic nerve is bigger. That may mimic glaucoma. Actually, that is not a glaucoma. Coming to the basic eye examination after visual acuity test, we do a slit lamp examination. Slit lamp examination magnifies the eye and let you see the section of the eye at different levels so that you can understand whether there is any abnormality in the structure of the eye, starting from the angle of the anterior chamber. And recording the eye pressure is important with tonometer and optic nerve head examination. Angle examination is of utmost importance. This is a very usual gonio lens used by the glaucoma specialists. 4 meter glaucoma, 4 meter gonio lens, and this gives you a nice view, and you can really understand whether these angles. I hope you can identify these structures, because this brown portion is your iris, whatever is visible from the outside of the eye, what you can see. And this is the sides. This is the end of the iris. This is the root of the iris. And here, the angle of the anterior chamber, this looks like this with the normal structure visible. If the structures are not visible, then it is a closed angle. And you can suspect that the aqueous is not going to pass out through the trabecular meshwork through the angle of the anterior chamber easily, and the pressure is going to rise. Okay. I think some problem in the interface. Am I still audible?
Yes, sir. You are audible, sir.
Okay. Somehow the presentation got hanged actually. It's not moving. I think let me restart the program because it is not responding. I'll come to this slide, and from here onwards I will. So hope is visible again.
Yes, sir. It is visible, sir.
Okay, just here. Yes. I think some problem is there in that particular slide. That's why after coming to the slide, it's stopping. Problems with presentation. Anyway, what I can find in the slide sorter view is that next we'll be moving to the diagnostic methods. And I think from here, let Mrs. Ramyani take charge, and she will complete the diagnostic tools. After that, we can be back with this presentation on glaucoma. Okay, so I'm stopping to share. Yes, I have stopped sharing, and Ramani, you may start the presentation, which will tell us about the different diagnostic processes and diagnostic tools which help in glaucoma diagnosis, not only diagnosis of detection, but also diagnosis of progression, because this is a progressive disease, and unless intervened at time, it may cause blindness. So over to Ramani, with the permission of the moderator.
Yes, sir.
Hello? Hello?
Yes, ma'am.
Yes, you are audible.
Yes, you are audible. Yes, you are audible. Most welcome, Miss Bhattacharjee.
Thank you. So today I'm going to tell you about the glaucoma investigations. The first and foremost, the glaucoma evaluation, sir, is already discussed. So, hello, am I audible? I don't know.
Yes, you are audible. Please.
Thank you.
Yeah.
Okay, thank you. The first and almost, sir has discussed about the evaluation part. Optometrist, when a patient is coming to an optometrist, if the first and foremost thing an optometrist can do is to check the intraocular pressure and the cup disc ratio, at least. Besides, taking the family history and systemic disorders are also needed, are to be taken into account for a proper investigations. The basic glaucoma investigations are the perimetry or the Humphrey visual field, the central corneal thickness or the pachymetry, fundus photo. We take a photograph of the fundus in order to document the optic disc changes, the OCT, RNF, and the HRT. This is how a Humphrey visual field looks like. This is the machine. This is the examiner, and the patient puts his chin on the place where it's a bowl shaped. I'll come to this. Basically, a perimetry test or the visual test measures all the parts of your eyesight, including your side or peripheral vision. To do the test, the room should be dark. As I have shown in the previous slide, one is a lighted room, another is a room in the dark condition. The room should be dark, and you sit and look inside a bowl-shaped instrument, which is actually called the perimeter. While you stare at the center of the bowl, light flash. There is a button in order, there's a button which you have to press each time you see a flash of light. A computer records the spot of each flash, and if you pressed the button when the light flashed in that spot, the computer records the flashes of light that you are pressing on the button. At the end of the test, a printout shows if there are areas of your vision where you did not see the flashes of light. It means that by mistake, like you are feeling that you saw a light and you pressed the button, but actually there was no light. These are areas of vision loss. These are the places where actually there is loss of vision. That's why you couldn't see the light. Loss of peripheral vision is often an early sign of glaucoma. The perimetry test usually takes about 30 to 45 minutes if both the eyes are tested together. Sir has already discussed the types of visual field defects. I won't go much into it. Just actually there are the arcuate knife fiber nerve fibers, which are the most sensitive to damage, then the macular fibers, which is resistant to damage. And the central vision is preserved till the last in glaucoma. Progression of visual field defects in glaucoma. There are basically the progression of field defects we can divide into 4 stages. One is the early non-specific changes, which are called the isopter contraction and the bearing of blind spot. Then there are the early significant changes, that is the peripheral nasal step, the small wing-shaped paracentral scotoma, and the sickle cell scotoma. Then we divide in the 3rd stage, this is the late significant changes, that is the arcuate or the germ scotoma and the ring or double arcuate scotoma. And the last is the advanced glaucomatous field defects, which is the tubular vision or no light perception. These are the type of prints or printouts which after the testing of the field, that is in the Humphrey visual field, when the printout is taken, it will look somewhat like this. This is particularly a printout of an enlarged blind spot. Then this is the superior arcuate scotoma. This part is completely dark. The patient could not see the lights. Then it's the germ scotoma. The nasal step. This is the double arcuate scotoma.
Sorry to interrupt. If you can please make the presentation in full screen mode, everybody will be able to see the. Yeah.
Okay.
Not that one.
Just
presentation mode. Down the window, can you see down on the right side there is a percentage? 68%. Just tap the button on the left side of it. Yes. Tap the button on the left side of the 68%, that whatever. Yeah, this one. This will call the slideshow. Just no, not that one. Not that one. Not that one. Not that one. Just come out. Tap somewhere else. Tap on the picture. Yes. Now go there back again. Just no, don't tap on the percentage.
Okay.
Just go out. You need to tap on the slideshow. Yes, this one. Yes.
Okay.
Yes. You can see the picture in a better way. Yes.
Okay. Thank you. I'm so
Okay,
novice in all these things.
No problem. Okay. Please continue.
Yeah, thank you. Next comes the pachymetry or the CCT. Pachymetry, the ultrasound pachymetry or the corneal thickness plays an important role in evaluating glaucoma. Patients with thicker corneas may show a high reading of intraocular pressure and vice versa. The normal corneal, central corneal thickness is around 520 to 540 micron. This is a painless test and is measured using a probe called a pachymeter, which is gently placed on the central cornea to measure its thickness. This is the probe. This is the probe, and this is touched in the central part of the cornea, applying the local anesthesia drop like parakin or something, and then then the reading is taken. The reading shows in this screen. And then we note the reading of the central cornea. The next comes the fundus photo. Optic disc changes in early glaucoma. In early changes are the retinal nerve fiber layer atrophy, the vertically oval cup, asymmetry of the cups, large cups, splinter hemorrhages. In advanced glaucomatous disc changes, which I have already told that in advanced glaucoma, there are tubular vision and no light, basically no light perception. So these changes can be seen when there is a, already sir has discussed about the retinal nerve fiber, the optic nerve head, all those things, and basically seeing the position of those things, we know that whether the glaucomatous glaucoma is in an advanced stage or the or in which stage it is. These are the few things which we see in the advanced glaucomatous changes: the marked cupping, which is more than 0.7, thinning of the neuroretinal rim, the lamellar dot sign, vascular alterations, nasal shifting of retinal vessels, bionating sign, bearing of the circumlunar vessels and overpass vessels, multiple hemorrhages at disc, and glaucomatous optic atrophy. This is the final thing. Recording and documenting disc changes. Serial drawings after seeing fundus by ophthalmoscopy or slit lamp, disc photography, HRT, OCT, and nerve fiber analyzer. This is a normal fundus, and actually we take the photo of this particular fundus in order to know that what abnormalities are there in case of a, or else we can know that in which stage the glaucoma is. This is the normal fundus. If any abnormality from here, then only the ophthalmologist can know that what in which stage it is. This is the normal fundus. This is basically the glaucomatous disc. From here we find out the cup disc ratio and this. Different stages of glaucoma of optic disc change in glaucoma. This is the normal, and these three are the glaucomatous changes. The first one is a very mild stage. This is a moderate, and this is the severe glaucomatous change. The fundus image. This fundus image, if this part is zoomed in, then we see something like this. This is a normal fundal image, and this is a glaucomatous. Here the glaucomatous change, the cup disc ratio. This is how you see a normal person can see a view through his eyes, through her eyes. The normal person will see like this if they are seeing any image. But in case of vision loss in glaucoma, due to glaucoma, a person will see this kind of image. He or she won't be able to see the peripheral vision. Next we come to the OCT, or the optical coherence tomographer. This is how it looks like. OCT is a diagnostic technology which produces a cross-sectional image of the anterior eye and retina in vivo with high resolution similar to a histological section. In glaucoma, it allows detection and measurement of retinal nerve fiber layer thickness, that is the RNFL. OCT technique. In the presence of clear media and cooperative patients, quality images can be taken even with a 3 mm pupil. Otherwise, dilatation is recommended. The patient is seated comfortably in front of the machine with chin position on the chin rest. He is asked to fixate on the fixation target. The internal fixation target, which is commonly a green light, actually there is seen a green light target, is commonly used as fixation target. Those patients who are unable, usually the patient is actually asked to fix at the green light, and the examiner can move the target from this position to that position. Like it can be, the target is basically movable. Those patients who are unable to fixate with macula can focus with the opposite eye on the external target. After fixation, the operator selects the desired scan and aligns the instrument so that fundus image and scan beam is displayed on the screen. This is a normal OCT with the retinal nerve fiber layer analysis. This is the Hiddleburg retinal tomography. This is how it looks like, and this is the report that we get. HRT is a diagnostic procedure used for precise observation and documentation of the optic nerve head, essential for the diagnosis and management of glaucoma. This laser does not harm the eyes, is focused on the surface of the optic nerve and captures the image. Sir, I think we'll be able to tell the exact how the report and all, those kind of report you all like how it is diagnosed, which layers are seen, and this. Hello?
You are audible, ma'am.
Okay. So I'm again.
Yes, sir. Yes, Ramyani? Can
yes,
you
so I
can
was,
you stop sharing?
Yes, sir.
Stop the sharing window.
Is it? Yes.
Okay.
Thank you,
So
ma'am.
at this point of time, yes. Thank you, yes, Ramani. Thank you so much for elucidating all the diagnostics tools and how they are done to all of us. At this point of time, before we go to, I would like to take up the questions. I would like to know from the moderator how much time we have left, because we started a little bit late and initially with some glitches. So how much time is left? So on that basis, we can discuss our topics. From our part, I don't have much thing to. Yes, tell me. Yeah.
Sorry, sir. We have sufficient time based on your availability, sir. Due to the technical glitch, initially we faced some issues, but not an issue, sir. We will take the questions and we'll discuss those, sir.
I think better take the questions first, then I'll go to the management part.
Okay.
Okay, sir. Sir.
Right. Okay.
Good morning, sir. This is Pablo here. I am
And
taking up the questions.
also, sorry to interrupt again. I mean, you're all free to ask questions in either Bengali or Hindi or in English, whichever language you are comfortable. The whole idea of this program is to communicate. Unless there is some communication, no lecture is going to solve any problem. And we really want all of you to get involved in this program so that you have something when you end the program, you have some take-home message with you. Okay, so please feel free. Yes, yeah.
Thank you so much, sir, for briefing us about the glaucoma on this wonderful day. I think we have got two questions from the audience. One is there any precautions we can take to stop patient from going into the glaucoma for taking the longer duration of treatment? Because we all know that we take a lot of treatments, lifelong treatment for glaucoma for the irreversible vision damage. So is there any precautions the patient can take?
Basically, when we talk about the treatment of glaucoma, the whole thing is a preventive treatment. Glaucoma cannot be cured, and it's an established fact, except for a few kinds of like in angle closer. Somebody telling something? Somebody is about to ask some
Another
question.
question. Yes, sir. Another question, sir. How often we should go for eye checkup to diagnose and to understand whether the patient is having a glaucoma or not?
If you are a first degree relative of a glaucoma patient, like what we have been telling, if your one of your parents or your site is having glaucoma, please get a checkup every, say, 1 year. Or depending on the situation, because at the first instance, if the doctor says that you have having some kind of glaucoma suspicion, some changes are there which may lead to glaucoma in future, then the protocol will be 4 to 6 months. Or if everything is fine, you can do it every year. It all depends on what the situation is, and depending on that situation, your doctor will advise you accordingly.
Okay. So we have another question from Sovik Chandra. He is asking that if the fluid accumulation is quite intense, can the
Okay.
vision be restored by corneal replacement or else any other method? He's asking about the fluid intensity
Now,
in the cornea.
if the fluid collection is too much, then the pressure will be very high, and that is what is commonly encountered in particularly the angle closer glaucoma, because there with a blockage in the drainage system, the fluid passing stops suddenly, and there is a block. The intraocular pressure goes up very rapidly, and there is a lot of pain with immediately loss of vision. And that if the patient is coming within time, before getting a permanent damage on the optic nerve, it can be restored. At least to a large extent, it can be restored. And the treatments are not only medical but also laser and surgical many other times. So
Okay.
it depends on the stage and depends on the time. So take home message will be, if you are having a sudden pain in the eye, sudden loss of vision in the eye with intense pain, or sometimes if you are having a headache, one-sided headache, please do check up with your eye doctor once before we go to the medicine doctor as usual.
Thank you so much, sir. It was really very wonderful. I think this was a very important question. Another question coming from Ashish Saxena. What is phacoantigenic glaucoma?
Phacoantigenic glaucoma is the lens protein itself is antigenic to the eye, particularly if it leaks out. This happens, what I showed in the secondary glaucomas, the lens-induced glaucoma. If the lens protein leaks out of the eye, it acts as an antigen to the eye structure itself, and it causes a blockage of the trabecular, the meshwork, the outflow channels, and that can give rise to a very acute kind of glaucoma picture. And also after cataract surgery, if some lens protein is left behind, that is called a phacoanaphylactic glaucoma. That causes an anaphylactic or antigenic reaction in the eye that can give rise to glaucoma. So it all depends which stage you are finding it. If the lens itself, hypermature cataract or the leaked out protein itself is the cause, then removal of the lens just the way of cataract surgery with some extra precautions definitely solve the problem. And if it happens after the cataract surgery, some residual protein is causing this problem, then that can be a chronic treatment with a prolonged medicine for that.
Thank you so much, sir. Next question is coming from Kingshu Mukherjee. He is asking what is the cause and management of low or normal tension glaucoma?
Low or normal tension glaucoma, we will come to the management basically in the next session. It all depends actually, that is a variety of the primary open angle glaucoma. Primary open angle glaucoma where the intraocular pressure is frankly high, and low tension glaucoma where the intraocular pressure is low, or normal. Still there is progression or changes of glaucoma that's going on. In both the cases, reducing the intraocular pressure is the treatment, and only one modifiable factor is there in our hand so far, that is the intraocular pressure. And though there are things called neuroprotection and other mechanisms, but those are not clearly established without the control of intraocular pressure. So even if the pressure is normal, further reduction of the pressure can be targeted. That thing is there in the next part of the presentation.
Another question from Devika Laik. She's telling that is there any direct impact of hypertension on glaucoma? Association of hypertension and glaucoma.
Previously, hypertension used to be a risk factor for glaucoma, but recently it has been removed from the risk factor, unlike diabetes mellitus. The reason being, hypertension, if you look at the eye structure, if the blood pressure is too much reduced also, then the ocular perfusion pressure, that is the oxygen supply pressure that is required in the blood vessels around the optic nerve also falls. So if that oxygen supply pressure is reduced, then it causes further damage. And hypertension itself didn't show any direct association with glaucoma. Not that if the blood pressure is high, the intraocular pressure will be high, except for some situation when there is increased pressure in the episcleral veins, that can cause a reduction in the backflow of the blood from the eye. That can cause a high perfusion pressure, and the backflow of the blood itself will cause some stagnation, and that will give rise to high intraocular pressure. Then that gives rise to a very bad kind of glaucoma.
Okay, sir. Next question is asked by Sovik Das. He's asking what is uveitic glaucoma?
Uveitic glaucoma is one of the secondary glaucoma. When the uveitis is the first problem, the uveitis, probably there is some kind of inflammation in the anterior or posterior part of the eye, and that inflammation itself causes some inflammation in the outflow tracts also, with the inflammatory cells blocking the outflow tracts of the eye, and that causes a glaucoma. The primary treatment should be targeted to control the uveitis, apart from reducing the intraocular pressure.
Thank you, sir. That's all questions we have. Another question. Okay. If someone have glaucoma, what change in its lifestyle may help him to cure? Shovik Mukherjee is asking this question.
Okay. I would take that question in a different way. Is there any restriction for the glaucoma patients in his lifestyle? Okay, so that will answer a few more aspects. Suppose you are having glaucoma, somebody is having glaucoma, and you're asking me what are the activities you can't do. If you are having glaucoma, please do avoid any kind of exercise that involves breath holding, like you are taking full inspiration and holding your breath for a few seconds and then releasing it. Those kind of exercises should be avoided. Why? Because that kind of exercise immediate intraocular pressure rise due to the Valsalva effect, and that kind of effect will cause a chronic damage for the glaucoma patient. For normal persons, the pressure rises and comes down, it doesn't affect much. But when the optic nerve is already compromised, that will produce some problem. So that kind of exercises has to be avoided. Breath holding of any type, and some asanas and some exercises with head down and legs up posture, like for example Sirsasana and Sarvangasana. Those kind of asanas are better avoided. If you are a windpipe instrument player, for example, a flute player or a sinai player. So you need to hold your breath for a longer time, and those things can be a problem if you are having glaucoma. Yes, and also if you are a driver and you are having advanced glaucoma, you know that the side vision, the visual field has been compromised, and unless you turn your head or turn your eyes, you cannot look at a particular direction. I mean, you cannot see a particular things coming from the sides. For those kind of patients, driving is, I mean, not advised, at least in the dark or the evening, because those are the times when the contrast sensitivity is, I mean, very less, and in bright light somebody can still manage, but it will be a problem in the dusk. So those are the activities that need to be avoided.
Okay. Sir, another question, optometry related question we have, that is there any relationship between soft contact lens users and glaucoma, or is glaucoma patient can use contact lenses?
Glaucoma patients can use contact lenses, but we tell them to avoid that because of some other reasons. Because glaucoma medicines, if they are using, that will contain some preservatives, and that will be deposited on the contact lens. So that will damage the contact lens basically. And also, if the patient is having angle closer kind of picture, then having a hard contact lens may cause a corneal warping, and that can be a problem in certain closer of the angles. So these two situations we generally try to avoid.
Another basic question has come, which type of glaucoma is painful?
Angle closer glaucoma is the most painful thing and very sudden thing.
Okay.
And also neovascular glaucoma, that is a secondary glaucoma, and neovascular glaucoma is also very painful, and almost there is no cure for that.
Okay. Another question has come, how optometrists are important in glaucoma diagnostic? How will be the follow-up for POAG, means primary open angle glaucoma?
Optometrists do have a very vital role in the glaucoma, not only in the glaucoma diagnostics, but also in glaucoma follow-up, because they are the persons who help us in detecting a fresh glaucoma or a progression in glaucoma. Because unless this visual field test, if you are doing a visual field test regularly, you must be knowing how important and how stressful it is for the patients. The small dots of light coming in and going out, and sometimes they are being bright, sometimes they are very faint. Actually, what we try to do is we try to pick up the faintest of the lights that a person can perceive. So making the person to see the faintest of the light need a lot of perseverance and patience, because the old patients, they will fail to respond properly, and you really need to have a lot of patience to make them see those small lights. So optometrist part is very vital, definitely. And with the if the OCT, in the OCT test, if the straight obtained, then whatever reading you'll get everything in red, as if large kind of damage has occurred, but actually nothing has happened. Only thing, the signal strength is less. So doing these procedures perfectly helps a lot to the clinician. Not only helps, they're vital. Without that we cannot work, we cannot diagnose, or we cannot treat basically. So optometrist, if you are listening, all of you have a very vital role to play. So please, while in the glaucoma clinic, while doing the glaucoma metrics, please be very meticulous so that your doctor can do justice to the patient.
Okay. Silpa Kormokar is asking, constantly using smartphone can cause glaucoma?
Like what? Smart phones are, I mean, more notorious for causing dry eyes, as well as the laptops. Glaucoma doesn't have any association as of now, straight away like that.
Okay.
So,
Kingshuk Mukherjee is asking, sir, can hypemia or hypopyon be, if not resolved, results glaucoma?
I didn't get that. Hyperemia, hyphema,
Hyphema means
hyphema. Yes,
accumulation
yes.
of blood inside it.
Yeah,
And
yeah.
hypopyon.
Hypopian is something else. Hypopian is either infective or a reactive. Hypopian has to go because hypopian cannot be allowed to stay there. Hypopian staying there means, some infection, some severe kind of infection is there. So hypopian is ruled out. Hyphema I have shown in the presentation. Yes, hypoma is if some intraocular hemorrhage is there, that comes under traumatic glaucoma. I have shown in the presentation. Yes, that is not
Another
used for
question.
glaucoma.
Okay, sir. Another question is coming. A glaucoma lady with pregnancy is there. Any
Yes.
extra precautions have to be taken as measurements while
Yes,
taking measurements?
it will be difficult because making the patient lean forward and sit for that long time, it will be difficult. And also, if you make the patient lean forward with a large abdomen, and if you try to take the intraocular pressure with that posture, the pressure will artificially be recorded high. So you need to use a tonopen and make the patient sit in a reclining position, so that will relax the patient and take the pressure with the help of a tonopen or EFR tonometer or rebound tonometer. Those are the instruments of choice in that kind of situation. But if the patient can still lean forward, probably ablation tonometer is definitely, you can take that.
Okay. Another question from Surajit Chakraborty is coming. He is asking what causes the unilateral transformation of corneal endothelium in the iridocorneal endothelial syndrome, ICE syndrome.
ICE syndrome is known for the malformation of the endothelium, angle structures, and iris. The name itself suggests that there is some malformation, some abnormality. So that's why the cornea is already weak in those cases, and they can give away and they can go for a decomposition.
Okay, sir.
Okay. So I think, is there some other questions also coming up? What I can see is in the chat box, I can see, sir, does bleb plays any kind of role in glaucoma management? Bleb, I think you may be asking about the trabeculectomy bleb.
Yes, sir.
Okay. Yes, bleb itself is one sign that the intraocular pressure is being under to some extent controlled, because some amount of aqueous is passing through the blade, and that definitely reduces the intraocular pressure fluctuation. So yes, having a blade after a trabeculectomy operation is the primary aim, and it is desired. And yes, regarding having a blade in kind of in a patient is important in the fact that after a trabeculectomy surgery, one has to be very cautious not to go for a swing for the rest of his life, because blade is a weak thing through which there is direct communication with the anterior chamber of the eye. So if any kind of infection goes under the blade, that will be communicated directly into the eye. So there will be lot of problem of having a very severe infection like endophthalmitis if somebody is having a bleb infection. So if somebody is having a bleb, please be cautious not to get a trauma, not to go for a swim. And the cosmetics also sometimes may be avoided, some kind of things. Cosmetic contact lenses also can be avoided, because if that abrades the bleb, there will be a bleb leak and there will be a problem, particularly with the thin cystic blebs. So that's it.
So one
question is
from our first year student. She has asked, sir, common symptoms of glaucoma by which a normal person can get prevention from it.
That is the problem basically. Glaucoma, most common variety of glaucoma is the primary open angle glaucoma, and that does not give any symptom. There may be some vague symptoms like any heaviness in the eyes, or maybe sometimes watering in the eye while symptoms. Most of the times it is asymptomatic. That is the problem. That is why we are talking about glaucoma so much, so that everybody is, is aware of the entity called glaucoma.
Another question from Onimesh Kormakar. He has asked, sir, blue light filter glasses can be used for glaucoma precautions?
No, that does not have any protection for glaucoma itself.
Okay. Arunabha madam is asking, can cosmetic cause glaucoma?
Usually, many of the cosmetics may have some component like steroid. If that is chronically used, that can cause glaucoma, yes. Otherwise, no.
Sir, you want to say cosmetic surgeries?
No. I didn't get you.
Sir, you want to emphasis on the cosmetic surgeries or the cosmetics which are given on the skin?
Cosmetics. I think she asked about the cosmetics. No? Cosmetics
Yes.
used in the eye.
Exactly, the
eyelashes or something. Yes, eye cosmetics.
Exactly.
Yes. Yeah.
Another question is coming, sir. Diabetes having any impact on causing glaucoma?
Yes, diabetic patients are more prone to have glaucoma, definitely. Yes, because the diabetics have a very common mechanism of having micro ischemia to the vital organs, and ischemic damage is more prone to have, give rise to glaucoma. So, diabetes, I mentioned in the presentation also that diabetic is definitely a very important risk factor for glaucoma.
Okay. Another question is there, why is there a forward rotation of ciliary body process in Clay 2ID syndrome?
That is a structural difference. In some body, it will have a forward rotation. That is a structural variation, basically. You can call it manufacturing defect of what? Okay. So, but the detection of plateau iris is important. You detect these are the cases after peripheral iridotomy. Also, you'll still have a shallow anterior chamber. Shallow peripheral anterior chamber. That is due to the forward rotation. That ciliary processes itself pushes the peripheral iris, and that is not cured with iridotomy also. And there are some other typical features also.
Okay. One of our PHM students is asking, what are the stages of glaucoma? I think it's already discussed.
Yes, yeah.
And another question is coming, what does negative Siddle test means?
And, I would like to know what a positive Siddle test means. Well, just to answer that question, Siddle test is done to check whether is there any leakage in the surgery site after glaucoma, mainly because glaucoma surgery is very different from other surgeries. We have to have some process through which the aqueous should come under the conjunctiva, but from not out of the conjunctiva. So if it is coming out of the conjunctiva, there will be problem. There will be chance of getting an infection going under the conjunctiva and inside the eye. So to check that, we do a test called Siddle's test with the help of a fluorescent stain, and a negative Siddle test means that there is no staining, no leakage of aqueous coming out. So that is good. Positive Siddle test means that aqueous is still leaking, and that should be closed, depending on the number of days after surgery. If it's a very fresh one, leakage is common, but if it is old one, then probably it is a abnormal thing and have to be addressed.
Okay.
Okay. So I think well, let us go to the last part of the presentation and finish it. Okay. Shall we? Or some other questions coming up? I think
most
we'll
of the
take the
questions
questions
are
at the
coming
end.
from the treatment. Most of the questions are coming from the treatment.
Okay. So let us go to the management part. And Just for the audience, meanwhile, while I go to the treatment part, meanwhile, let me know if you want to see any kind of surgical video. I have one or two ready with me, but I really don't know how much interested you will be to see them. If you are by anyway, if you are interested, then I can, or else just, let us just hold the discussion that we are doing so far.
One of our student is saying yes, sir. Please.
Oh, I'm so surprised. Thank you. Okay, let us go to the presentation end, then we'll come back to that. Regarding the management part, there are mainly three main stages of treatment. Of course, the first line are the eye drops and tablets. Though tablets are temporary, eye drops can be used for a long. And depending on the type, laser can be employed at the beginning. And of course, surgery is the second line of choice. Obviously, there are situations where surgery is the first line of choice, like for example, in congenital glaucoma. In those cases, a surgical treatment is more often required than not. And moving on to the coming into the medical management, there are some considerations like setting the target intraocular pressure. Now, target intraocular pressure is a very favorite topic for the examiners. Previously, it used to be more favorite, but still, if you are having some presentations or if some student is having some examiner from ophthalmology or glaucoma, you'll be asked about target intraocular pressure. So these are the considerations. Having a target intraocular pressure at which the intraocular pressure has to be reduced so that there is no further worsening of glaucoma. And for that, medical management has to be planned. And lasers can be required for different purposes. For angle closure, it's a different purpose. For open angles, it's a different purpose. And surgical glaucoma will follow next. And newer thing in line is the neuroprotection, that is trying to protect the neuron, the nerve. Well, regarding target intraocular pressure is the upper limit of intraocular pressure that prevents further damage. And intraocular pressure lowering reduces the risk of visual field progression in glaucoma patients. So intraocular pressure still remains the single most important modifiable factor that has to be or that can be modified in a glaucoma patient. Without intraocular pressure modification, no treatment of glaucoma is complete. And these are few few uses of laser in glaucoma: in iridotomy, in trabeculoplasty, in iridoplasty, in goniophotoccoagulation, and in cyclophotocoagulation. Iridotomy is making a small hole in the peripheral iris where the communication of the anterior and posterior chambers of the atria segment is made, so that there is no aqueous collection behind the iris and angle closure is obviated. Trabeculoplasty is using a laser on the trabecular meshwork itself, so that there is increased filtration in the trabecular meshwork itself, and that can be helpful for reducing the intraocular pressure. Iridoplasty is to mold the iris in such a way with help of laser coagulation, so that the iris is dragged out of the peripheral anterior, so that angle of the anterior chamber is opened up. Gonophotocoagulation is used to photocoagulate any neovascularization in the angles, and cyclophotocoagulation, either a transcleral or a endoscopic cyclophotocoagulation can be used to burn the ciliary processes itself with the laser, so that the aqueous production is reduced. But these photocoagulation procedures are reserved for the, very recalcitrant type of glaucoma, so that they are used as a last resort of glaucoma. So just to prevent, because if the procedure works in an uncalculated manner, then there will be a phthisis of the eye, that is softening of the eye with a loss of the. So those should be kept as a last resort. A few pictures of the SLT lasers and endoscopic cyclophotocoagulation. On your left, you can see the direct visualization of the endoscopic machine, through which you can see the ciliary processes, the dentate, like tooth-like processes, the ciliary processes, from which aqueous humor is formed. And this is just a schematic trabeculectomy picture. I use the Olympian spawns as an adjunct. A small communication is made with a partial thickness sclera. This is the partial thickness sclera, and through which you can see the aqueous is coming from the anterior chamber and going out of the out in the subconjunctival space. And this elevated subconjunctival structure is called the bleb. Somebody was asking me about the bleb. This is the bleb. And next important surgical procedure are the valves. That can be a non-valved implant, where there is a valve body and the small tube. This tube is inserted either in the anterior chamber or in the vitreous cavity, so that the aqueous is drained out of the eye, and this large footplate acts as a reservoir around which capsular fibrosis occurs, and this capsular fibrosis itself resists the uncontrolled outflow of aqueous, so that the anterior, so that the intraocular pressure is maintained. And there may be plants like a glaucoma valve. When these are implanted, these have the advantage. The tube will open only after the pressure of intraocular pressure of 8 to 12 millimeter mercury is built up. Only then it will open up, or else it will remain closed. And the newer Indian edition of this is our Aravind aqueous drainage implant. In short, they call it RD. And this is a modification of the valved non-valved implant. But the advantage of this is much more cheaper. So management is, so please remember that glaucoma is a lifelong disease, and use of drops and tablets, if required, has to be done regularly. And glaucoma requires a continuous monitoring. Please don't think that you are using a drop or you have undergone a glaucoma surgery, so you are safe, everything is cured. No, nothing is cured. Nothing is curable. Whatever is there, it has to be maintained till the end of life. Till the patient is alive, he should maintain his vision. Nobody, our aim states that nobody should lose vision in his lifetime. That is the basic aim we have as glaucoma doctors. And no eye medication without doctor's approval. Please don't use any kind of medication, be it a skin ointment also, because many a times it is seen that steroid skin ointments can cause through systemic absorption, it can aggravate glaucoma. So please ask your doctor whatever medicine you are using. It may appear it is not related to glaucoma, but please inform your doctor about that. And glaucoma is often hereditary, so if somebody in your family is having glaucoma, please do get a checkup by an ophthalmologist, and by someone who can see the posterior segment also, because optic nerve examination and the anterior chamber assessment are two vital things which are often missed. due to either ignorance or due to just patient came for casual checkup and you do a casual checkup also. So these two things has to be mandatory, and a regular eye checkup after 40 years stays mandatory. Usual presentation, but if you are interested, I can show you small clips. Of surgery, if you want to see. Do you have time?
Yes, please.
Okay.
Yes, sir.
Okay. Let me play the trabeculectomy video first then. Let me see whether I can share this. Is it visible?
Yes, sir. Not yet, sir.
Oh, I think message is coming on the. These are the small tips surgeon should know. That's when I made this video. So anyway, I can tell you from here that dissection is measurements are taken. Thickness scleral flap was lifted. As an adjunct to prevent subdiagnosis, and 5 meter apex partial thickness scleral flap was lifted. And small punch is done. This actually acts as the, so you can understand this is the anterior chamber here, and there is a communication, and through this communication the aqueous will come out in the subconjunctival space, and then a releasable suture is used. The releasable suture gives us the advantage of removing the suture from outside, so that your if the intraocular pressure is going to be high in the postoperative period, it can be removed, and more egress of aqueous is achieved, so that the intraocular pressure is further reduced. So that's about it. And I will take a little more time to show you a small clip of the valve video, so that you can have some how it is done. I will show you a video of a RD valve. Just one second.
Yes, sir, it's visible.
I'm playing the video. After the usual conjunctival dissection, the RD being a large valve, it needs a rectus dissection also. so that the rectus muscle, hope you know there are 4 rectus muscles. The valve is then placed, and you can see the priming of the valve, so that the tube of the valve is filled up with water. See that is filtering freely, and this is then placed between 2 recti muscles, and anterior that valve is secured with suture, and tube is then placed at the desired position. In this particular case, eye being a post penetrating keratoplasty, and that is a graft. So we avoided the valve placement in the anterior chamber. We rather placed it in the vitreous cavity, so that directed away from the cornea, so that no further corneal damage is done. Because he anyway needs a corneal transplant, and the tube should be away from the cornea, so that the cornea is more secure. So that's about it. I mean, just wanted to see how it is done, just to have an idea. Here, and if any further question is still left, I'm here.
Okay, sir, we have one more question from Arunava madam. Can radial keratomy lead to glaucoma?
Radial keratotomy used to be done for myopia, and that is out of fashion these days because of its high complications. The radial keratotomy used to weaken the cornea itself. It will not cause a direct association with glaucoma, but if glaucoma is there in a patient with a radial keratotomy, he or she will have more chance of getting a corneal rupture. With high intraocular pressure, often the incisions used to open up, and with minimal trauma also it used to be opened up. So anyway, radial keratotomy is not being done these days. There are much better options in terms of LASIK and photodifractive keratotomy. Okay.
Sir, another question to Ramaya madam. What problem we have while performing perimetry?
Okay, Ramani madam should answer this.
Sorry, sir. Actually, madam is having some technical glitch. Her audio is disconnected.
Okay.
So, if you could.
She has come back. Yes.
Yeah. So, ma'am is here, but our audio is disconnected. So, if you like answer the question, sir.
Okay, no problem. The most common difficulties we face during perimetry is the compliance. That faint light and making the patient sit for that long is really difficult. And with the aged patients, if there is one machine at your center, please do it yourself, and you'll understand that even in a young age also, how much concentration you will require to do a successful perimetry test yourself. That will tell you how much difficulty an old person will face while doing the perimetry test, and it's really involves a lot of patience.
Okay, sir. Thank you so much, sir, for that answer. Next question is coming. What is the difference between trabeculotomy and trabeculectomy?
Trabeculotomy is done for congenital glaucoma that involves the rupture of the anterior wall of trabeculum with the help of Ham's trabeculotome. And trabeculectomy is done, what I have shown you, direct communication with the anterior chamber with the undersurface of conjunctiva, and both can be combined. Many times when operating on congenital glaucoma, we combine both these processes into one. I didn't know that you are so much interested in congenital glaucoma also. I have nice videos of the procedure, and I could have shown it here, but it's okay. I think time is up.
Okay, one of our intern student is asking, by mistake, if I put a mid-periodic eye drop in case of the patient who is having VH grade 01, how can I manage this case instantly?
Basically, if you put pilocarpine in that case, that is not going to help much, because if once you put a dilating drop, the pilocarpine cannot revert it immediately. Immediately, some amount of dilatation will occur. So you please inform the doctor who is treating the patient, so that he can take care of by using systemic medications like in form of acetazolamide, or maybe sometimes intravenous mannitol, to reduce the intraocular pressure that is going to go high immediately. That has to be addressed, so that it should be treated in the same patient while treating a acute angle closure crisis.
Okay, thank you.
At least the rise of the intraocular pressure has to be assessed with for the next few hours. Make the patient sit there and continue seeing the intraocular pressure time to time, so that you are sure that till the pupil has constricted, the pressure has not gone up, or if it has gone up, you have treated the patient adequately. Not all the patient with a shallow chamber will go for an acute angle closure crisis, but there is a fair chance, particularly if the vanage grade 1 is there.
Thank you so much, sir. It was a great pleasure, very much interactive session. I think many of our students, those who are performing in hospitals especially, and those who are studying glaucoma for the first time, they will be very much benefited from your lecture, your and ma'am. Thank you, both of you. Now I give this session to Pradipta sir for feedback.
So thank you, sir. Thank you, Pablo, sir. Before I propose the vote of thanks, I'd like to read the message from our principal, ma'am. So ma'am has expressed her gratitude. It was a great session. Thank you, sir and ma'am. Looking forward a great and fruitful partnership in the days to come. Now, sir, officially I should propose the vote of thanks, but it was really a learning session that I cannot want to propose this vote of thanks. But however, we had to end this session. So respected and our most distinguished chief guest and key speaker for the day, and Dr. Surajit Chakraborty and Ms. Ramyani Bhattacharjee, respected principal Dr. Bhattacharjee ma'am, our beloved Professor Atorno Maulik, head of the department, Optometry department, honorable professors, and my dear students. I deem it's a great honor to propose a hearty vote of thanks to our key speaker, Dr. Surajit Chakraborty and Ms. Ramyani Bhattacharjee, for gracing students' webinar. Thank you, sir, and thank you, ma'am, for your very interesting and detailed presentation. I'd like to express our profound gratitude to our principal, Dr. Unava Mukherjee, for her constant inspiration and her presence in this particular session. I'd like to thank our beloved head of the department, Optometry department, Professor Maulik, for his support and guidance. I'd like to thank Professor Pablo Chandru and Dr. Ratnokirti Roy and all other my colleagues who have been running around doing a lot of things. Thank you very much, all of you. Finally, the wonderful students who have turned up in such great number, not only from our college, but also from other colleges. Thank you so much for your cooperation. Thank you, sir, Dr. Surajit Chakraborty, for answering all those questions and for your great deliberations. It was a pleasure to have you with us. Now this concludes this webinar. Thank you all for attending. We hope you have learned and enjoyed this session. So thanks to all of you.
Thank you. But one thing I'd like to mention, probably you have been recording this program. So please make this program available to all of your students. And if you are broadcasting this program on Facebook, probably somebody can see to this program afterwards also, is it?
Yes, sir. Yes, sir. We are recording this program, and as well as this is a live Facebook live. So students can go through this particular program afterwards also, sir.
Okay, that will be great for them, basically. They can understand the program. Whatever they have not understood in this program, or any gray area remaining, please let them contact with you. And
yes, sir.
possible in future, I can also clarify any of the doubts. They might be
definitely, sir. We look forward to a long-term relationship. And thank you, ma'am.
Yeah.
Unfortunately, your audio is not connected. So it was really, really nice for your presence, ma'am. And thank you, sir. Thanks to all of you.
Thank you then. Bye.
Thank you, sir.